Hello, everybody. Welcome back to the show. This is the Science Dispatch podcast. I am your host, Cameron English, joined as always by Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, how are you this wonderful day?
I am peachy keen. It's all good.
I like it. I like that reference. It's a bit of a throwback. It's a good one.
It's even a throwback for me, and I'm already a throwback. So
it's all good, right? The vintage is the stuff that lasts.
I hadn't thought of that. I'm really vintage. Yes.
There you go, right? Just Americana, baby. That's all it is. Okay, we've got a pretty short story to discuss today. This is called Finally, Someone is Listening to People in Pain. This is by Red Lawhern, a longtime contributor to the American Council on Science and Health, advocate for pain patients. He's been very critical of the CDC and the DEA in recent years for what he calls, in so many words, an assault on pain patients who just can't get access to adequate pain control in the form of opioids typically. And so in this article, he's talking about a recent presentation that he and some other prominent advocates of this community made to some leadership at the FDA. And he's hopeful that this will lead to some policy changes. So let me read the introduction here, Chuck, and then, of course, as the physician, I'm eager to get your take as always. So Red writes, with the real opioid crisis in 3 charts, a patient advocacy group has briefed senior FDA officials on major changes needed to public health policy for the regulation of prescription opioid pain relievers and doctors who prescribe them. Perhaps now someone is truly listening to people in pain. Okay, Chuck, so he's got, looks like 6 or 7 key bullet points here. Tell us what's going on. What's most important?
Okay. Well, I think, hope springs eternal in the human breast because he went to a listening session. I'm not sure that he went to a listening and paying attention session, so I'm not completely sure that things will change. He brought up a number of points that he and Josh Bloom have been making at ACSH for a long time, beginning with the fact that the opioid crisis was not the result of the physician prescribing behavior during that period of time. That's not completely true, but it's certainly physician prescriptions were not the big evil in the process that led us to the opioid epidemic. And they've been arguing about it for a long time. But it's been very easy to control physician prescribing behavior because physicians, by their very nature, do what they're told. We have been trained to get the highest scores possible on the MCATs and all of our exams. So if you just tell us that if you prescribe in this manner, you get a high score, we tend to follow that. And as a result, the CDC released some guidelines in 2016 that Red and other people have pointed out has a lot of scientism in it rather than science, and has some bad assumptions that led to the CDC making some recommendations to physicians about how they manage chronic pain patients. That would have been probably okay by itself because guidance is just the guardrails. But the legislators, because they felt the need to do something, took the guidance and turned it into law. So you took a bunch of thoughts and suggestions and turned it into red line rules. And that's led to a lot of difficulties for physicians that were practicing pain management to continue doing it in a way that met the legal requirements. And so a lot of them dropped out and left their patients hanging because there's a limited supply of physicians and almost unlimited supply of patients. And that's led to a lot of problems. So they addressed a lot of those concerns with the FDA. They also talked about the fact that the CDC and the DEA, which are the organizations that apply the drugs that the FDA approved, may have overreached in their behavior. Certainly the fact that for reasons that are beyond my understanding, the DEA determines how much of pharmaceuticals are allowed to be brought into the United States seems to be an overreach on the part of the Drug Enforcement Agency. I understand that they're doing that on the basis of controlling the supply, but they have no actual training in pharmacologic supply chains, and so it just leads to problems. And it's led to problems in terms of shortages of ADHD drugs, pain medications, any of the medications that may be prone to abuse that they have control over. They've limited the supply and caused problems for all the people that are using it for legitimate reasons. So I think that they try to speak about a lot of those points in there. I'm always torn with these articles because I can see a little bit more on both sides. One of the places where Josh and I most vehemently disagree is when they talk about these stories about the doctors that I would describe as running a pill mill and that Josh would describe as providing needed pain services are convicted of crimes by the DEA. And in many cases, the crimes come down to the fact that these doctors are not documenting in any meaningful way the reasons for what they're doing, which is a requirement under the law. But some people would argue that's not worth 20 years in jail. On the other hand, when you're looking at seeing 30 patients an hour, you have to begin to wonder what actually is going on during that examination and whether they're doing any examination at all. And that does get into the area of fraud, which then makes time in prison at least more reasonable. So we kind of go back and forth over that. The other area that I think Red brought up that he showed concern about was that the national opioid settlement requires the distributors of drugs, including the small pharmacies, to keep track of who they're dispensing the drugs to. Now, this was the case before, and all of the red flags, all that information was overlooked by the DEA and was not reported by any of these distributors. That's why they're facing fines. And so the new regulations are meant to tighten that up to require the distributors to provide that information back to the DEA. So I don't have a problem with the DEA knowing my prescribing habits, because the truth of the matter is that every pharmaceutical company buys data so that they know my prescribing habits so that they can come out and target me to prescribe drugs. So this is not something new. And that I think that if, likewise, we identify people that are going through a significant amount of drugs that may be used for recreational purposes, let's put it that way, it's worth at least inquiring as to what's going on. That doesn't mean a wholesale blanket, pull them into the office and see, but it certainly means that it may be worth taking a little bit of a deeper look to see why they need that amount of medication, if for no other reason from a medical point of view. And there very well may be a reasonably innocent medical reason. But oftentimes, under the where there's smoke, there's fire clause, there are other things to find.
It's a tough balancing act because I think you're right. There is pretty good evidence that you had straight up pill mills that were just dispensing OxyContin and other drugs willy-nilly to people who had an envelope full of cash, right? You know,
Yeah.
my night blindness is really bugging me. I need some pain relief or something. That did happen.
Yes.
And Sally
Dr. Feelgood is a real person.
Yeah. Sally Sattel, who's an addiction specialist from Yale, pointed out in some interview I listened to a couple years ago that was drug legalization, because a lot of the people who want relaxed prescribing on opioids are also advocates for legalization. And she said, well, that was it. And that's part of what got us to where we are. Even if the reaction has been unnecessary and exaggerated, this is part of the problem. So I think you have a point there. The flip side that really alarms me, and I think I'm curious to get your thoughts, is that you had physicians who were doing right by their patients and were prescribing responsibly, who were nonetheless prosecuted by the DEA. And I've heard physicians say, I was in court and the DEA put someone who was woefully underqualified on the stand as an expert witness. And then they would say, you prescribed this many thousands of pills. What do you have to say for yourself? And they'd say, well, you don't have any information on the patients I prescribed those to. You have no idea why I gave the dose that I did. In other words, it was information stripped of context, right? The things you would need to properly assess that. And so you had some doctors go to jail or lose their life savings or lose everything fighting the federal government in court. What's your take on that?
So that gets to a problem of documentation that, and which I tried to allude to before. Nobody really trains physicians well in how to manage the medical record. There is no special class that we take to do that, and that's becoming increasingly vital. It was important to do when I was in training because it helped the passage of information from one doctor to the next, and that was the rise of SOAP notes and any number of ways to structure your writing so you covered all the bases and that somebody could pick up the chart and know what was going on. Today, with the advent of the electronic health record, where some computer company designs the forms, it's a completely different horror story. But the basic problem still remains. And then this is where I get hung up on it, because if you say, well, there was a lack of context, but the physician is the one that's responsible for providing the context in the medical record. I never saw a case where the physician wrote, the person is taking 200 morphine equivalents, but it is not controlling him, so I am increasing it to 300, get into trouble. Because he says what he did, why he's changing it, and what he's changing it to. So there's the context. The problem is these people that have shoddy records. Now, the shoddy records may not indicate criminal intent, but that's why a lot of these guys ran into trouble, is because they have no record. Somebody came in, I saw them there, everything is fine, out they go. And I mean, and if you went back and you looked at my notes in my own clinical practice, and this was before the advent, this was right after the abacus had come out and before the computer, there were a lot of things in there that were completely extraneous to that. And I would try to put the information in there. We talked about the risk and benefit of the procedure, and we decided to do it. And I would write that in because I knew from a malpractice point of view that I needed to document that. But I didn't always, put in the notes why I changed their Neurontin from 100 to 200. I tried to at least establish that. But again, as I said, there was no training in actually how to document things. And the other place where you see this problem with documentation, where it gets to be an interesting criminal problem, is that oftentimes in the notes that are written in the chart in the hospital, there are hospital employees from utilization review that go through those charts every day. And they have one eye towards the ultimate coding of that, so that they will ask questions. They'll put little stickums in the chart for the doctor to answer in the notes so they can clarify and properly code the case. And in a lot of cases, those questions lead to upcoding of the hospital stay. I mean, my favorite question that I always had was a person who would come in with some gangrene of their toe, and they were smokers and they had diabetes. And so the diabetes is listed. And then the question would always be, did they get the gangrene from the diabetes? Well, no, they got the gangrene from the smoking, the diabetes, the heart disease, the cholesterol. But they wanted me to say diabetes because diabetes got them a bump on the payment. And so that kind of documentation we learned after we got out. But the documentation that's needed to provide care never really was there. So I understand why the doctors are concerned about it. I understand why the DEA is concerned about it. I don't think people should go to jail for poor record keeping, but oftentimes poor record keeping is associated with other problems for the legal system. So it's a question of correlation, not causation. Am I allowed to say that?
No, fine, $500.
Okay. I'm just paying on the way out. I mean, I think the other thing that Lauren brought up that was interesting is the use of the term opioid use disorder for pain patients. And we've talked about the various substance use disorders, and there's a huge behavioral component that's part of the diagnosis of that. And I think he's correct that a lot of these patients that have been labeled as having an opioid use disorder are being labeled on the basis of the amount of medication they're getting rather than the behavioral aspects. These are people that have jobs and are doing the things that they need to do. And the only times that they're running around and stop what they're doing in order to get pain meds is because their doctor is no longer prescribing them because he's out of practice or because he can't do it anymore.
It's a very good point, and I think it goes to a reality that a lot of people are not aware of, which is that, if you get cut off meds you've been prescribed, you start looking for other doctors who will do it, and by definition you're drug seeking, and therefore
yes,
it's possible to classify you with opioid use disorder. So I think that's the kind of circle people have been forced to run in until, in the extreme cases, they kill themselves because they're just. It's like, well, I just lay in my bed and drink alcohol all day, or I try to find heroin on the street. I think those are the extreme cases that have been often overlooked. And that's the part that's troubling to me, is that I've seen people, nothing extreme like that, thankfully, but I've seen people close to me get injured and be prescribed anything and everything except the obvious choice, what would be just, a reasonable dose of opioids for a few weeks, few months, what have you. And like you mentioned, right, gabapentin or a muscle relaxer or, this placebo, because there's some trial somewhere that says that we can condition you to think that a placebo will treat your pain. And there's absurdities that are coming out of this, I think, that are driving people up the wall. And those are the things. Yeah.
Yeah. The other thing that interesting is that a lot of their red flagging is done by the numbers and by computers. And that will yield them a net full of suspects. But they don't then turn it over to humans to sort through the pile. And I think that is an increasing problem because while the numbers may suggest that there's a problem, until you dive deeper into it, you don't really know what the context of those numbers are. Simply a guy that's prescribing that has 500 prescriptions for narcotics going out to his patients may raise some concern, but if they're doing pain management and this is the only place within 100 miles, already it's starting to make sense why it's that, but you have to have a human actually go out and look at what's going on rather than just say, let's open a criminal investigation.
Well put, Dr. Dinnerstein, as always, balancing the equation that so many people don't want to balance, right? There are some extremes in a discussion like this, right? It's either drugs are great, people should get as many as they want, or it's this kind of hyper-prohibitionist, a la Dope Sick and Painkiller on Netflix, where, you take one opioid pill and pretty soon you're a fiend and you're...
Well, I had 3 major operations over the course of 3 years, and I received 8 Percocet for one of them and nothing for the others. And to be fair, for reasons that are beyond my understanding, Tylenol worked just as well. For the case where I got the Percocet, but otherwise, and I just don't, You know, it's just craziness.
Yeah, there's a lot of diversity, to use another popular word, because some patients respond differently. That's one thing Red mentions too, is that that seems to have been overlooked, is how different people metabolize these different drugs, how big they
Yeah.
are, et cetera, et
Yeah.
cetera. Right. Everything's
All,
been sort of conveyor belted, if you will.
all things that have to be hand sorted, that don't, that actually require, you'll forgive the four-letter word, work to discover.
Yes, indeed. Healthcare is increasingly becoming like cafeteria food. Everyone gets the same serving of potatoes, mystery meat, and peas. And if you don't like it, that's too damn bad.
Okay.
Let's wrap it up here. Really quick before we go, we had a listener question recently because we talked about long COVID on an episode a few weeks ago, and you had written an interesting article based on some research that apparently discovered perhaps plausibly one of the mechanisms behind long COVID. And we had a listener write in and point us to an organization that is, I guess, hypothesizing that long COVID is primarily in people's heads, that it's something they've been convinced is real, and therefore it is real, almost like a nocebo effect, perhaps.
Mm-hmm.
And it's interesting because this seems to have been an outgrowth, at least for the listener who wrote to us. This is an outgrowth of some of the claims about pain management, where you have major medical schools and health systems saying, well, we can train you to think your pain is in your head. And there is some research that there are certain conditions that you might be able to treat with placebos, and there are things like your mind is very powerful, to be certain. But I think when you're at the point where you're going, you had open heart surgery, let's just teach you that it didn't actually hurt as bad as you think it does. So that's the origin of this. But I'm curious, and maybe we can do a full episode, but what do you make of this claim that people who say they have long COVID
Well,
have sort of ginned it up?
it gets once again into the fact that long COVID remains a syndrome, and it's a collection of ill-defined symptoms and very few objective signs or findings. And so for a lot of people, they present with this and the doctors cannot find any kind of underlying objective cause. And so everybody needs to have a diagnosis. Everybody needs a treatment before they leave. So saying that it's all in your head may not be the most satisfying of answers, but at least it is something we can treat, because I can give you a drug for something in your head in that regard. So I think it gets caught in that. The usual problem with this group is you have to be able to definitively rule out a physical cause before you're asked to say that it's primarily a psychologic phenomenon. And with long COVID, because it's so ambiguous, it's hard to say that you've ever reached the point at which you've exhausted all the possible physical causes. I think over time we're getting to start to narrow that down. And there's probably a group of people that are suffering from some kind of COVID PTSD that leave them feeling that way. But I think that it probably represents the minority of people. And then in a lot of cases that there are some underlying physiology that we don't quite have a good grasp of that may be explaining in a way. I mean, in a world in which you can get bit by a tick and no longer can enjoy having a steak because it's made you allergic to steaks, we're going to have to open up our thinking to consider that there's other things going on in the world that we don't quite understand yet.
That's wild. Of all the terrible health effects that can befall a person, that's the one that quite scares me. Not being able to eat a New York strip because some bastard bug bit me.
That doesn't need to be fair.
It's not. The world is not fair, and I particularly dislike that example. Okay, so as we wrap up, what I'm hearing you say is there's still a lot for us to learn about long COVID. In some cases, perhaps people are suffering some mental effects, and that could be part of what's going on here. But in the majority of cases, correct me if I'm wrong, there is some underlying physiologic mechanism, and we just don't know how to pinpoint it yet. Something to that effect?
That's where I would come down at the moment. Yes.
Very good. Okay. So as time goes on, as always, more studies needed.
Hey,
NIH, dole out the grant dollars. Let's get to the bottom of this in the name of public health.
big study, baby. Big study.
Yeah. Yeah. Big study. Okay. We'll leave it there. As always, follow us on social media where we are at ACSH.org on Twitter. I am at CamJEnglish. Go to the website, acsh.org, click the subscribe tab, punch in your email address. We'll send you all the stories we publish. And then when you come to the show, you'll know what we're talking about. You get a little bit more out of it. And of course, as you just saw, we respond to listener questions. So send us your comments, your questions. We'd love to hear them. And with that, we will see you next time.